Now Subhash is going to speak on delivery of femur and
It's a complete
step by step.
DA step by step. So I think the ball has been set rolling by everyone by showing you how DA has been evolved over a period of time, and good to see a full house. May I see the raise of hands? How many of you are doing DA at this point of time? And how many you want to learn DA?
Who can stop anybody to learning?
No. Great. So few hands are there. So you have seen all the steps in the different ways, and my job is to make you show the videos how it's been done real time. So just a disclaimer that my training approach was posterior when I was trained in my PG, and I'm gradually getting confidence in getting the DA. The results are more or less the implant position remains the same whether you do a DA, posterior, anterolateral or lateral. So there were apprehensions when you move from one approach to another. Was there any challenges when I was seeing my patients with my posterior approach or the DA? The acetabulum exposure was probably as good as it was in any other approach. And the femur was also having not much of a problem. Whether you get a DA or a posterior approach, you just have to get the exposure right. That's the key. Was there any problem in the satisfaction of our patients with the DA or posterior? Not much of a difference. Maybe by the end of 3 weeks, DA were doing much better than the posterior, but a lot of people have their different opinions. Everybody does the same way, but the patient's effect also matters in the result. So the concerns were that what will I gain by the new approach? There was learning curve of 20-25 cases. Special instruments are required for few things, but not for all things, and special table is not required at all. So few tricks and what things needs to be changed. So when I was getting training with the DA, I was told that this is support on the opposite side, because when you try to adduct and interrotate the hip, the patient moves on the other side. So you need to have a support on the other side. We did the left side few weeks back. Now we're doing the right side. So this support has to be not on the ASIS, it's on the greater trochanter on the other side. That's the first change which I did after doing few cases. If we prepare both the hips, both the lower limbs. The other thing is that there has to be a sandbag under the gluteal, just proximal to gluteal fold, because all that fat or sag will be sagging behind, so that it's easy for you to lift the femur out, lever the femur out. And the table break. You see, I was trained that the table has to break at the ASIS, but again, I would recommend the table has to break at the GT level rather than at the ASIS. So that's where the table breaks. So that's the incision, about an inch posterior and distal to the ASIS, and a standard approach, and it goes towards the fibular head. So once you incise, you see that a blue kind of fascia, the muscle visible from the deep fascia, and that's your tensor fasciae lata muscle. So once you see this tensor fasciae lata muscle, just anterior to this is the sartorius, and you have to just remain on this blue muscle, that's on TFL. So once you're on this TFL, the advantage is that you will prevent the injury to the lateral cutaneous nerve of thigh, because that is anterior to this, almost an inch and a half anterior to this. And once we cut this, what we do is we take these two small arteries, and that lift the fascia above, and with the finger dissection or maybe with just a blunt dissection with your scissors, you just have to separate out the TFL from the fascia. You should be able to see the fat just medial to the TFL, because beyond that is the sartorius. Until you see that fat layer there, the whole is the, so you are seeing that everything is now on the lateral side, the TFL, the medial is the sartorius, and you're right on the front of the hip joint with a fat pad there. So you can avoid this lateral cutaneous nerve injury of thigh by just lifting it with the cautery. Now once you are there, you're right at the back of the anterior hip capsule, and you can see the fat pad in front of the hip capsule. Now you have to put these two homens, one is superior and one is inferior to the neck. So one goes at the saddle between the greater trochanter and the neck junction. So superior one is going there, the inferior one is going inferior to the neck. Once you put these two homens there, I'll just fast forward. So once you put these two homens there, you are seeing the neck profile right in front of you. That's a capsule in front of you. So you can do a capsulotomy as we have been discussed, like an inverted T, H, whatever you want to do. So I initially used to preserve this capsule, but after learning from a lot of people who are doing regularly, the capsule preservation is not important. It rather comes in between when you're reaming, doing broaching. So it's better to remove the capsule. So you can do an H, T, whatever you want to do, you can do that. The next is that you reflect the anterior rectus femoris reflected head, and you use a cob or the periosteum elevator to lift this up, and you're bang on the anterior column of the acetabulum. Then you have to two homens are there on the superior inferior, and anteriorly you have to put a homen there. This has been 8 minutes, I think I just will take some, yeah. So you can put an anterior homen there, and you can see the whole of the capsule is right in front of you. And then you have to do the capsulectomy or capsulotomy. The other modification which I did over a period of time is that you can release the whole capsule from there superiorly and just remove the whole capsule from there. It will also add up to your superior capsular release. And move from there, and you can also release the superior capsule right at this point of time when you are able to see the whole anatomy very properly. So as you can see, when we are moving laterally, we can release the whole capsule superiorly also at this point of time. So then you put those two homens inside the capsule, and you can see the neck profile right there, and do a cut. You can do a wafer cut, you can do a simple cut. After that, the delivery of or removal of the head, you have to use the head screw, and you just rotate full 360 degrees so that all the adhesions, because this is not a normal hip, they have adhesions, arthritic hip. So once you do that, all the adhesions are removed, and then you have to just lever it out, and it comes out easily. And you can measure that size if you believe that the acetabulum size has to match +2 or 4 millimeter of that. So that's the removal of the head, and then you can sometimes have to remove piecemeal if it's a very deformed head, you're not able to bring that out. Next, at this point of time, we do the femofemoral release as well. So you have to release this up to the lesser trochanter as been mentioned. You just have to external rotate the leg, and you can reach on the medial side right at the level of the lesser trochanter. Now, these simple homens, you can put one anteriorly, which I showed, taking the rectus anterior. One is at the tal, one is on the posterior side. And you have a beautiful view of the acetabulum. Now, if you're using a different approach, now the problem is that you have to see in a different angle, as shown by 9 or 6. So it's now opposite side. The tal is on the anterior side. So you have to ream accordingly. And once you prepare, then you can put a trial cup there. You can check under image intensifier if you want to, but nowadays we hardly see that, and can put a final cup there. Now next is the femoral delivery, which is one of the most trickiest part of the surgery, which people think that's probably more, and there is a learning curve for this. So, but you just have to learn what you have to release. You have seen that pyramid, and I'll just show it in these two videos. If you see there on the top side, so that's the 12 o'clock. This cautery goes vertically up from the 12 o'clock position. We move from there to in this direction. That's the ASIS there. So you have to go from vertically there. And the key is that once you release this, your finger has to go in so that you are on the lateral side of the trochanter. So after releasing this, I'm putting my finger there to see that I can go easily in. That you have to be on the lateral ridge of the trochanter. That's the key. So once you reach there, then you can put your double prong molar there, which is sitting on the trochanteric lateral ridge, vastus lateral ridge. If it is not there, you tend to break the trochanter, because if you try to lever it out without reaching there, that will break the trochanter. So that's the key here. Once you are there, you see the whole of the neck is right in front of you in a beautiful profile. So that's the exposure you get. You don't release this area. You release here superior capsule, and there's your anterior border, and there's a medial border. So that's the only interesting instrument you require just to lever this out with a double prong. You can also use a blunt Homan there. This we have already seen. The important thing is once you release the conjoint tendon and you're still not able to deliver your femur out, there's a reset button. That means something is wrong somewhere. Maybe something you have not released properly or your instruments are not in proper position. Just reset there, and if required, you can go for the piriformis release as well. So even without breaking the table, you can get the femur exposure. So there is no need for any special table. There is no need to break the table. If you release are proper, you can even bring the femur out without any major issues. You need these offset handles because if you want to broach in line, it's difficult because that molar will come in between. So these offset broaches are required just for the femur. So advantage that you can measure the limb length, the stability. You have seen the patient sitting cross-legged easily, and they recover very fast as well. The one important thing when you choose the patient is that this working distance. If the patient is a coxa vera, the anterior inferior iliac spine will be very close to the GT, and then it will be difficult to deliver the femur out. So these are the cases where this is short. Those are not your ideal cases to begin with. Once you gain experience, you can do that. That's very, very important thing to note when you're seeing a pre-op patient X-ray. I think it's worth a shot if you want to learn the technique. And because people who come for the follow-up, they are actually walking without stick. They sit on a low seat, no problem with that. And thank you all for patient hearing.
Thank you, Subhash.